sleeping. So they can sit there deprived of oxygen, deprived of nutrients, and still be alive later because they're in a dormant stage. We then did a dog study with the University of Coimbra in Portugal, in which we did either apexification or regeneration procedures in dogs. And then 3 months later, we looked at the tissues. And the caveat here is that we induced apical periodontitis in all teeth. So all teeth had pulp necrosis with lesions. So basically, if you do MTA apexification, what's going to happen with the apical papilla is this right there. It's completely calcified. Okay? So basically, this shows that the apical papilla was alive, because if it was dead, it wouldn't be there to calcify. So we know it's alive. And it calcifies because MTA is very osteoinductive. But if we do regeneration, then in some cases we had tooth development. And in this case here, I'm going to show you this case because I thought it was very interesting. The apical papilla is down here. It came out from the outside of the root. So basically, when we try to make that apical papilla bleed, we pushed it out. And we pushed the papilla into the lesion. And I thought that was quite interesting because I think it happens maybe with our patients too. And if you do a zoom of that apical papilla, you're going to see that it calcified itself. It's surrounded by PDL. So it has a PDL. And if you zoom even more, you're going to see dense node tubules. Basically, the apical papilla developed away from the root by itself. It's quite interesting. And then I went and asked myself, can this happen to patients? And the answer is yes. There are actually few case reports, like this one, showing the apical segments developing completely separate from the rest of the root. So basically, what I'm trying to show you is that the mechanical trauma that we do when we do these procedures might not be the best thing, because we could completely disrupt the apical papilla Hertwig's root relationship. And then this comes from San Antonio. This study here came from a case that my resident was treating this tooth right here. This young girl had apical abscess on and off for 2 years. And then finally, she came to our clinic. And then I told my residents, go ahead and use a Hestrom file on the walls of the canal. Be very careful to disrupt biofilms. Not to shape, but to disrupt biofilms. So he went a little too deep, apically. And then he called me and he said, hey, Dr. Diogenes, I have a piece of tissue in the file. And I said, that's the apical papilla. And he wanted to put it back inside the tooth. I said, no, 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 don't put it back, give it to me. So I went to the lab with the piece of tissue. And then he looked at me and said, now what? I said, now it's an apexification. Start mixing the MTA, get ready. So that's the tissue in the Hestrom file. And then I cut it in half, and you see the apical papilla is white. And what you see apical to it is the lesion, right on top of the apical papilla. And then I cultured these cells and did flow cytometry, showing that these cells have all the mesenchymal markers. And not only that, they differentiated into mineralizing phenotypes. And they did here in green better than the cells that came from a healthy tooth. Not only they're alive, they were primed for differentiation. Came from a tooth with an abscess. So I think that pretty much sets the tone that yes, the apical papilla survives and stays there. That's great. So this is the classical triad of tissue engineering: stem cells, growth factors, and scaffold. In medicine, in regenerative medicine, this is what they talk about all the time. And we've gone a long ways. There's a lot being done, to the point that now they made a hamburger completely made out of stem cells. Hamburger patty is right there. The first time that they made this beef out of stem cells, it cost $380,000. more than $300,000 for one hamburger. And then this guy said, okay, let's do a food contest and have people eat it. And people lined up and they tried the stem cell hamburger and they also tried the normal hamburger and they gave their opinions. And the story on the report says that they said that it tasted very good, but it was a little dry. It didn't have fat. And the researcher said, no problem, I put some adipocytes in there, we can make fat. What is the percentage that you want? And now they can make that beef for $10. It dropped the price from $380,000 to $10. In the future, I don't know what the future holds. If we're gonna have stem cell beef in the future in a supermarket, I don't know, we're gonna see it. It's scary, but it's becoming true. Lot has been done in medicine. Dr. Von Ark said, it's amazing how far behind we are. It's no kidding, it's so true. In regenerative medicine, they were making trachea, windpipes. They're building windpipes in the lab and put it in patients. Patients that had accidents and lost the ability to breathe. Fully engineered windpipes, trachea, implanted into patients, and then they show the ventilation going from 0 to full, complete filled lungs through pipes, windpipes, trachea, completely engineered in the lab. It's amazing. We've gone long ways. But for us endodontists, we have a problem, and the problem is infection. We deal with an infected environment. And every time there is infection, any engineering, tissue engineering effort is lost. It's completely destroyed. How important is disinfection in treating immature teeth? I have the situation here, the apical papilla sitting right there, and the whole pulp is necrotic with an infection. Well, this is from NYU. Gang here, Dr. Louis Lin, Dr. Domenico Ricucci. This is a revascularization case, a regeneration case that went bad. It failed. They did histology, not surprising at all. They found biofilms. Why our conventional root canals fail? Biofilms, right? Microbes. It's not different here. It's very important for us to think and keep in mind that we're dealing with a microbial war. That's what we're dealing with on a daily basis. So the immature tooth has some challenges. Like what? We cannot aggressively shape the canals because the walls are very thin. We don't want to weaken those walls too much. There's large volume of microbes, right? Because the canal is large. Young immature teeth are more susceptible to bacterial colonization. The reason for that is because the dental tubules are wider. They have a greater diameter and they're patent. So it's easy for bacteria to get in there. But also there are some advantages. The advantages include that the root canal the complexity is very low. Roots are not bifurcated, they're very simple. The large volume allows for irrigation. You can irrigate and have fluid dynamics that is very good for disinfection. So there are some advantages too. And then this group in Brazil did 15 cases that were traumatized cases they treated with revascularization procedures. And then they did PCR, and they looked at the microbes that are present inside the root canal system. And they found this species right here. And I would like to point out to you that these species are not different than the species that we deal in adults when we do conventional root canal therapy. And that was their conclusion, is that the microbial profile is not different than that. Of course, they use PCR looking specifically for some species. I don't think this is 100% true. There's data coming out of our clinical trial that we did pyrosequencing that shows a little bit different. But nonetheless, we're dealing with a microbial infection that is basically what we deal anyways in our clinics. And Dr. Fuad, when he was still in Maryland, did this study right here in ferrets. And basically they induced apical periodontitis in ferrets and then later disinfected the root canal system and introduced a hydrogel and dental pulp stem cells inside. He saw two outcomes. Some, we had newly mineralized tissue and root formation that is very adequate. But sometimes they found this. The root didn't develop at all. And yet there's no apical periodontitis. When they looked histologically, they saw this, biofilms. So biofilm can be there to a degree that is low enough that it's not going to cause a lesion, yet it's going to completely stop regeneration. That's important to keep in mind as well. And the way bacteria does this modulation is not well understood. This is the work of my colleague, Nikita Ruparel, in our department. And Nikki, what she did was she got dentin and treated the dentin just like we treat in a clinic, with irrigation and all that. But some of the dentin was pre-infected with E. fecalis, and she allowed biofilms to form, and then disinfected that with clinical protocols, put stem cells on top of that dentin, and then looked at differentiation. What you see here is dentin sialoprotein, a odontoblastic marker, okay? And here's the fold expression. When there's no bacteria, stem cells love the dentin there and become odontoblast-like cells. When there is E. fecalis biofilm, this is almost completely blocked, just because bacteria was there previously. And what happens then is that they had a different differentiation. This is bone sialoprotein. So these cells became osteogenic, not odontogenic, just because bacteria was there ahead of time. So I think that bacteria leave fingerprints on the dentin, antigens that modulate the stem cells. Now we have evidence from our lab that's exactly what happens. Is LPS, is the lipopolysaccharides, different types that modulate the stem cells. So we have a challenge, no kidding. Because when it's sterile, it's odontoblastic differentiation. When it's infected, it's bone that's formed. And you, especially the young ones here, that in training, when you look at those papers being published, ask yourself, is this an infected model or sterile model? Because sterile model, we can get odontoblastic differentiation in my lab every day. But if it's an infected model, it's completely different. So our challenge is not just to disinfect. We have to detoxify the root canal system, okay? And we know that dentin is very important. Dentin has these amazing growth factors that can be released. We can release them with VDTA, for example. And we can treat the dentin with VDTA and then release these amazing growth factors. The cells love it. So this we already know. So let's talk about irrigation. This is the first paper that we published in irrigation. This is the Trevino paper. Basically, we did stem cells of the apical papilla with dentin root tips. They're basically pieces of roots that we put PRP, platelet-rich plasma, donated by us. We gave blood every day. And we put the PRP in there of the cells. The dentin was pre-treated with these different irrigation protocols. Here's what we found. When EDTA was used, we had the best results. Cells loved that environment. If hypochlorite was used, with EDTA, we dropped that in half. And with chlorhexidine in the protocol, everything got killed. This was the very first evidence that not direct contact, but pre-treatment of the dentin can cause a very lasting effect. But to tell endodontists that hypochlorite is bad is a bad idea. It's just like telling that their mother is ugly, you know, because we love hypochlorite. We're endodontists. So what is the challenge here? The challenge is not that it's bad. The challenge is what concentration is bad. So we did the same experiment and using different concentrations, varying from 1.5 to 6% hypochlorite, plus or minus EDTA at the end. So if you look at survival here, you see that 1.5 drops, 3% drops, and 6% is really bad. This is not direct contact. Hypochlorite is not touching the cells. It touched the dentin, and then the dentin was flushed with saline, and then the cells got in contact with that. I want you to keep that in mind, because it's indirect, okay? But if you do EDTA, you can reverse that. This is, in the y-axis, DSP, odontoblastic differentiation marker. Look at the effect. 6%, 0. It completely abolishes odontoblastic differentiation. Even if you do EDTA, you can only reverse very little. So which concentration are the best? 1.5 and 3%, right in the middle. And that's why the AAE recommendation says 1.5% to 3% at the AAE recommendation, based on these studies and other studies that confirmed these findings. Okay, is Chlorhexidine all that bad? And this is the work of Dr. Riyad Al-Thamari. He's in the audience here somewhere, up there. And basically, if we treat dentin with Chlorhexidine, Chlorhexidine has substantivity, right? Chlorhexidine, it's positively charged, excuse me, and it binds to negative charges. And the dentin surface has negative charges. So basically, Chlorhexidine binds to dentin and stays there. And the concentration here that allows cells to grow is about 0.0002. We use 2%. No wonder when we use 2%, everything dies, right? But can we reverse that? Yes, we can. You can use 2%, like here. 2% kills almost everything. EDTA is very good. And what we can do, we can reverse this effect right here by treating the dentin with a negative charge protein. Soy lecithin is a protein. We treated the dentin. Basically, we neutralize Chlorhexidine. So you can kill the bacteria, neutralize the Chlorhexidine, and now we're good again, like new. And this is in press right now in the Journal of Endodontics. So, again, growth factors in dentin are very important. Can irrigation release these growth factors and have a biological activity? Yes, absolutely. Especially TGF-beta. If you treat the dentin with EDTA, you will release copious amounts of growth factors, such as these right here. TGF-alpha, TGF-beta, CSF, VEGF, which is angiogenic, lots of good stuff just from dentin. And that has a biologic activity as well. This is the work of Maobing Yang from Temple University in the United States. And good news is, if we use ultrasonic activation, basically if you activate your irrigation with ultrasonics, you can increase the release of these growth factors. So not only ultrasonic is good to disrupt biofilms, it can be beneficial to release these important growth factors that we have. And it's so profound, in fact, this is the work of Kirsten Geller in Germany, that if you pre-treat the dentin here with EDTA, you put this dentin growth with dental stem cells in the back of an animal to grow for 3 months, what you're gonna see is what resembles a new pulp dentin complex there. Looks like pulp. The cells that line the dentin are polarized, they express DSP, and they have processes going into the dentinal tubules. Very good results. If you pre-treat the dentin with hypochlorite, 6%, and you do the same thing, you have this right there. Clastic activity. These cells became osteoclast. They didn't become osteoblast, or odontoblast, excuse me. So you see, just by changing the irrigation, you change completely the fate of this. So now we did it with really a different thing. Completely different than we ever done, because we just try to kill microbes, just irrigate and kill. Now it's different. How about medicaments? We have different pastes, different things that we can use, right? Double, triple antibiotic paste, calcium hydroxide is not a new concept. Antibiotics has been used in endodontics for a long, long time. This is not a new thing. It was introduced recently, more recently, by Dr. Hoshino in Japan. The concept was to use the combination of minocycline, metronidazole, and ciprofloxacin inside the chamber of teeth and allow that to diffuse into the canals. And in this publication, Sato, in 1990, they demonstrated that a concentration of 25 milligrams achieves full sterilization of the canal system by just diffusion. That process was, this concept was then adapted for revascularization procedures, but with a difference. They use paste of unknown concentrations. So we looked at the effect of these concentrations of paste on the stem cells, and what you're going to find here is, in a concentration-dependent manner, the paste or the antibiotic solutions kill the cells. And the concentration that we use clinically in the paste is 1,000. It's right in there. 0 survival. It's absolutely too concentrated. And if you ever mix this, you have no idea of the pH. The pH of that solution is about 3.7. It's a very strong acid, on top of being a drug. Calcium hydroxide, on the other hand, is very good. Cells love it. They don't die, they even grow in the presence of it. But, okay, stem cells survive. Can these concentrations, low concentrations, kill bacteria? Several studies have looked into this, including this one. And they looked at different concentrations of the antibiotic with different incubation times, and they found this. 1 is sufficient, 1 milligram is sufficient to kill, and you don't need even 2 weeks, 3 weeks, or 4 weeks. 1 milligram, not 1,000. Okay? Another study from a different group in Washington, Seattle, showing that it's 10 milligrams. 10 milligrams kills everything, and it doesn't stain as much as 1,000. This is how a root looks after triple antibiotic-based treatment, completely stained. And it's so profound that it stains all the way to the cementum. It's really, really bad. This is the work of Riyad Al-Thumari, again. And in this study, we wanted to look at what is the effect of treating the dentin, not the antibiotic on the cells, but if you treat the dentin with antibiotics, and then we flush the medication out of the canal, and we put the cells in contact with that, what happens? Dentin discs are made. This was treated with calcium hydroxide, this was treated with double, and guess, triple antibiotic based. The staining is profound. Control cells like it, right? They survive. When the dentin is treated with 1,000, no cell grows in there. If you treat it with calcium hydroxide, there is proliferation. And if you dilute this drug to 1 milligram, then you're good again. So it's not like the antibiotic is bad, it's the concentration that should be adjusted, okay? And very recently, in a collaboration with Dr. Siqueira in Brazil, José Siqueira, we did a clinical trial. And in this clinical trial, root canals were disinfected and then medicated with calcium hydroxide or antibiotic paste at a concentration of 1 milligram. So 1 milligram of triple antibiotic paste performed better because more teeth were bacteria-free than calcium hydroxide. With chlorhexidine, this calcium hydroxide has chlorhexidine in it. So it works. 1 milligram works. You don't need 1,000. And if you're worried about radiopacity, you can add a radiopacifier to that solution, and you get now radiographic evidence of where you put in the medication. So that's good. So as a summary for the antibiotics, we have the cell toxicity, that anything above 1 milligram is cytotoxic. Many studies have looked into this. And the concentration that is antibacterial is anywhere from 1 to 10 milligrams. I think 10 is a good compromise. 10 milligrams. Okay. So let's move into some clinical outcomes. I use basically 2 microscopes. This is where I spend most of my time, right here, in a clinic. But I also use this confocal microscope. And obviously very different. And including the price, this is probably 100 times more expensive than this. But this one, I make money, and this one, I spend money. So that's another difference. So let's look at first, what is the overview of the current procedures? This is a very quick video, so I'm going to try to explain to you how we do things. After access, irrigation, headstrong file, disrupting biofilms, and then we're going to irrigate with 1.5% hypochlorite, followed by EDTA, 17%. And then we medicate. We use calcium hydroxide in San Antonio. We use triple antibiotic paste if things don't go well with the calcium hydroxide. We temporize the tooth and seal it. And we try to do sealing with a glass ionomer to avoid any type of leakage. We use glass ionomer. Second visit, we go back in. Looks easy, right? Huh? Perfect. So we're going to flush it out with 1.5% hypochlorite, followed by EDTA, 17%. Of course, the root canal is dry, and then we're going to evoke bleeding. Now, many people say, well, it's hard to make it bleed. Don't use vasoconstrictors. And if you have a hard time, okay, this is a collagen membrane on top of the blood clot. This is a collar tape. This is a Zimmer product. Then we put a bioceramic. I no longer use MTA because of staining. This will be biodentin, followed by a layer of glass ionomer, and then composite restoration. Basically, in a nutshell, that's how we do it. Okay? Now, if you can't evoke the bleeding, my suggestion is use 2% lidocaine without vasoconstrictor. Do you have it here in Saudi? We don't have it as a dental product, but you can buy it as a medical product because they use it in dermatology. Basically, if you use 2% lidocaine, it's a potent vasodilator. The anesthesia is not going to last very long. It's going to last like 5 minutes, but you're going to get a lot of bleeding. So that's one way of evoking bleeding is by using drugs that will help you. Okay. What are the goals for the regenerative procedures? Primary goal, of course, is elimination of the disease. Secondary goal of increased thickness. And a tertiary goal is to get positive vitality responses. I want you to be careful when you look at the papers. You should look at whether they use standardized methods or protocols. Are they always using the same technique or not? Another one is, are they quantifying development or not? Are the etiologies the same? I'll show you cases here that it's mainly dense vaginatus versus mainly trauma. And you see opposite results. And if they have adequate recall rates, anything less than 2 years is a little bit complicated for these type of studies. And what is the criteria for success? You should keep that in mind. This is a meta-analysis that was done by Dr. Ahmadinejad that basically compiled all the studies in revascularization and regeneration and looked at the survival rate of MTA plugs compared to regenerative procedures, and they have basically the same survival rate. And they also have the same apical periodontitis healing rates. This is not statistically significant, this here, even though I believe there's a little advantage for healing for the MTA plug there. if you took out all the variations and everything. So what we have so far is that these procedures, if we just look at survival and healing, they seem to be very comparable. And in San Antonio, we tried in 2009 to develop a methodology to quantify changes in the radiograph. And then we did these linear measurements of root length and thickness, which later we revisited the methodology, and we came up with this radiographic root area that we can calculate and then determine whether there was development or not. Not perfect methodology. The perfect methodology would be CBCT. It would be volumetric 3D analysis before and after, no question. Because we don't have problems with angulation and you look in three-dimensionally, obviously. And of course, we don't have time to discuss the ethics of doing CBCT in children, but I don't see this as being a problem at all. Most of the cases are traumatized, and in trauma we take several PAs, right? Might as well take a CBCT. I'll skip this. Let's look at this study from NYU. This one differs from the others because it doesn't look very exciting. The results are not very good. And the reason for this is that all these cases were traumatized. All of them are trauma cases. So it's consistent in the literature when you look at the trauma cases. They have lower success rate, no matter what. It's true in revascularization too. You see less root development when there is a trauma involved as an etiology. This is the quantitative analysis of all cases, all studies, that looked at quantification, and you see the regeneration studies showing root development and apexification 0. So we can get radiographic development of teeth using these techniques. It's consistent with many studies. One study that I would like to point out to you is this recent study out of China, in which is a complete randomized clinical trial. They used AAE recommendations for protocol, and they did before and after CBCT. So they did volumetric analysis, and they showed that there is root development. Okay? And there's none when there is apexification. Healing rates are 100% for both, but only regenerative procedures had growth. But that happened in 82% of teeth treated, not in every tooth. And then what I like about this is that they broke down the cases by etiology. And look at this. I would like to show to you also this cartoon that I made recently that shows the different type of outcomes that you can get when you do these procedures. You can get no change, that will be bad. You can get type 3 that the root end just closes. You can get type 2 that you have development, but the root end is not closed. And type 1 will be full, complete growth with the root end apex closing. Type 1 is the most desirable type. That Chinese study here, if you look at the type 1, all the type 1 cases here, when there's dense evaginatus, 91%. It's dense evaginatus. Trauma drops to 33%. Type 2, it's about even. And then trauma has higher incidence of type 3 and 4. Basically less desirable. This is the first evidence, hard evidence, that shows that trauma has a lower root development outcome in these procedures. Vitality responses, in about half the cases we get vitality responses. Yes, it's not false positive. We know how to test. We can treat children. We can do this. It's reproducible. So we can recover that. Why and how? This is a case treated in Korea. It went from pre-op to post-op 10 months. This is a 10-month recall. The tooth was extracted. Guess why? Orthodontics. Orthodontist law of extracting premolars, right? So that premolar came out. And they did histology. What did they find? Nerve fibers. So this tissue is innervated. We got innervation there. What is the mechanism? How can we get neurons growing from the apex all the way up? We actually did experiments. We investigated that. Show you here 2 papers that we published. One is in press right now, showing that the dentin growth factors that I mentioned to you also promote neurogenesis. These are neurons treated with the dentin growth factor compared to control. And Dr. Obata Alstar is involved in this project. And this one showing that the stem cells of the apical papilla attract the neurons. So we have a cellular and a non-cellular mechanism of attraction of neurons. It's so potent that a group in Belgium saw our work and asked me to collaborate with them. Basically, we have now a series of papers showing that the apical papilla cells can reverse spinal cord injury. This is a study that we published in the Journal of Dental Research, that we did a contusion model in the spinal cord of rats, and those rats became paralyzed. And then later, we implanted the apical papilla inside the lesion, and some of these animals walked again. So that's really, really impressive. And we now have about 5 papers published in this area. So basically, it's knowledge from endodontics going to medicine in different areas. So that's something we should be proud of. I'm excited about it. I'd like to talk about this triad of outcome. This is really important. It's something that we think very hard in San Antonio about this. Because in endodontics, we are very focused as clinicians on what we see on the radiograph. And sometimes we forget the patient. What is truly important for the patient is what we call patient-based outcomes, patient-centered outcomes. They care that they don't have disease, basically it doesn't hurt, and they don't have swelling. They care that the tooth is in the mouth, and it's functional, and it looks good. And the looking good is usually very subjective, of course, but when they're children, they don't care. When they become teenagers, they care. Oh, it's this color, I don't like the way it looks. So that's a patient outcome. That's what they see. The clinician-based outcome is what we see. And what do we see? We see radiograph. Radiographic healing. We look at the radiograph and we want to see a lesion disappearing. We look at root development and we test vitality responses, right, in the clinic. That's us. The very top here is the scientist-based outcome. Histologic evidence. That outcome needs a scientific methodology. Basically, as a scientist myself, if I want to see if there is regeneration, I'm using science. I'm going to look at histology, I'm going to do all that. Patients do not care about that. They don't care if they have a odontoblast or osteoblast. I was never asked that question in one of my patients. So why is that important? Well, aesthetics is a big issue. Revascularization has been plagued by discoloration. There are 3 sources of discoloration. It's blood inside the dental tubules, MTA, right, and the medication. How can you avoid this? You can bond the chamber with an adhesive to avoid blood getting into the chamber. You can not use MTA, use biodentin or BC putty, and use calcium hydroxide or double antibiotic paste instead of the triple. You can avoid that altogether. This is a nice review on discoloration. What is the main reason for discoloration? Triple antibiotic paste, 68%, and the use of MTA, 96%. MTA can no longer be recommended to be used as a coronal barrier in this procedure. But which bioceramic should you use? We have different options, different flavors. We tested this by testing these materials. But before us, this is the work of Dr. Stefan Simon, showing that biodentin is very good and is odontoblastic in nature. It induces cells to become odontoblastic. And then we did the same, but now looking at MTA here. Biodentin, endosequence putty, and endosequence fast set. What you see here is survival of cells. Detail here. This is not just the material and the cells. This is the material in the dentin. The dentin has been treated just like we do in the clinic. And then the cells go on top of that. So MTA is not great for the cells. Biodentin and endosequence for survival is very good. How about differentiation? If you look at alkaline phosphatase expression, biodentin and endosequence are the highest. The cells are mineralizing more here. The SPP, odontoblastic marker, biodentin and the endosequence, was very curious that the fast set wasn't good. So I don't recommend fast set endosequence. Use the putty. But very interesting, the one that MTA did the best over here and over here is osteoblast. So MTA induces cells to become an osteoblast, not odontoblast. So guess what? MTA is great for apical surgeries because we're going to induce osteoblastic differentiation. Not great up on top because we want odontoblastic. Okay? Okay, how about scientist-based outcomes? Regeneration, repair. I love that Dr. Von Arx touched on this because the same discussion that is in periodontics is in endodontics. Is this regeneration or repair? Let's take a look at this. This is a case from NYU. This was irreversible pulpitis treated with a revascularization procedure. And then the tooth came out because it fractured. And then they looked at the tooth histologically. What did they find? Beautiful looking pulp. I mean, the pulp is there. It's formed all the way to the MTA. There are cells lining the walls. It doesn't get any better than this. This looks like the negative pulp. However, in the necrotic tooth here, also from NYU, and Domenico Rigucci is in here. This case was treated in Argentina by Gabriela Martin. And look at that. This is clinical success. Basically, there are no lesions. The canal obliterated, but the tooth fractured. And it was extracted, they did histology, and it doesn't look like pulp. It looks like there's cementum, there's bone in there. Lots of mineralized tissue, but it doesn't look like new dentin. Another case from Belgium, treated, extracted because of orthodontics. And Dr. Ivo Lamberts is a very talented anatomist. And he did a beautiful anatomy here showing what he calls osteodentin. And I really like the definition of osteodentin because it's a mineralized tissue that has cellular inclusions but is atubular. It looks a lot like the mineralized bridge that we get when we do capping procedures. Spec popotomies. You get exactly that, osteodentin. It's the same. Summary of all the histological case reports. You're going to have all kinds of findings. Dentin tissue and odontoblasts are usually associated with a viral diagnosis. When you have irreversible pulpitis, every time there is pulp necrosis, we seem to find something else. And I told you about the bacteria modulating the whole environment. So that, I think that there's some pieces that are connected. Is the glass half full or half empty? If you go from here to here, is this good, is this bad? When we do capping procedure, pulpotomy, this is the work of Dr. Rigucci himself. Human tooth with a capping procedure. What is this here? What is this formed? It's not dentin. It's already proven that it's not dentin. There are many methods that have been used showing that this new material is not dentin. At best, we can call it osteodentin. Yet, all of us endodontists will say, oh, it's a dentinal bridge. It's a dentinal bridge. It's not. It's a mineralized bridge, not dentin. So it's a different zip code. If it's okay in a crown, but it's not okay in the roots. That's my question into it. When we have PCO, like this tooth, what is formed over there? is osteodentin, is not tubular dentin. So traumatized teeth that calcify, if you do histology, you're going to more likely find a tubular mineralized tissue that doesn't resemble dentin. It doesn't matter. This is a case that I had to treat only because the tooth was discolored. And this is a very famous endodontist. And I had to find this canal and treat it. I was nervous. You don't want to perforate that, right? It's your friend, it's your buddy. We got it. But what is the tissue? Does it matter? Not to me, not clinically, it doesn't. True regeneration only happens with salamanders and other lower-end animals. And even then, the limb that is formed is not exactly the same. That's why I came up with this term, guided endodontic repair, just like in periodontics. What we get in is a repair, it's not regeneration. Bottom line is, and I'm okay with this, because it's guided by us. It's a thought process. We made it happen that way. If you walk away, it may not happen, right? So the aim is to replace damaged structures. It's different than the claim to be regenerating the damaged structures. That doesn't happen. We already know that. This is a good case that just came out, so I suggest students take a look at this because it's very interesting. These are two cases done by us in San Antonio with two different outcomes. Both teeth were extracted and we did histology in both teeth. What you're going to see here is a movie of the first tooth that I like to show. This tooth was treated successfully for 6 years. And then one day we received a phone call from a clinic in South Texas. And the dentist said, oh, I'm calling because we're going to extract the tooth that you treated. And we said, which tooth? We said, oh my gosh, is that tooth? Is that the regeneration? And then my colleague drove 3 hours to collect the tooth. When she brought the tooth back, we did micro-CT. It was the first thing we did, was fix the tooth and then did micro-CT. So you're going to see the micro-CT of that tooth. The root. It's going to spin this way, and I want you to focus on the lumen of the canal. And you're going to see a circumferential, newly formed mineralized tissue around it. Lots of calcifications. You see the ring, and then exits at 2 foramina. That's what we saw. And then we went further and did histology on that. But before that, the micro-CT core in San Antonio measured the radial density of the tissue and found no difference between the native and the new tissue on the walls of radial hardness of the tissue. Then we did histology, and you see here DSP, odontoblastic marker, being expressed by cells that have processes into the dentinal tubules. And look at the orientation of the dentinal tubules. They have a different orientation. And there are a lot of nerve cells. This is blood vessels in red, and nerve cells, nociceptors, CGRP containing nerve fibers in the pulp that's formed. So we know that we can have potentially odontoblastic cells in there, and we have nerve cells. And there's actually tubular dentin formed, not in the whole tooth, but in parts of the tooth. So what that shows to us is this possible. It's just we have bad control over the whole process. This is an amazing clinical trial by Dr. Song Tao-Shi, very famous person in stem cell biology, out of China. Okay? And in this one, they implanted dental pulp stem cells. They got these dental pulp stem cells from third molars, grew them in the lab, and then put it back in teeth of patients that needed regeneration. Amazing. They're already going through the next step, which is growing cells and putting back in people. And they did all kinds of analysis, including CBCT. So it's not a dental, it's Science Translational Medicine journal. It's not a dental journal. So very impressive. And then in one of the tooth was extracted. And look what they showed. Odontoblast-like cells lining the walls of this tooth that was previously completely infected. So it's possible. It's possible. It's just how we get there. Okay? Okay. So one of the things is scaffold, and we don't have a good scaffold. We've been doing blood clot for a long time. I've been reading a lot of other fields, what they do, including periodontics. And it seems like a lot of folks have different grafting materials. And a lot of the most advanced grafting materials now are decellularized tissue. Basically a tissue that has ECM, the architecture, everything is the tissue architecture, minus cells. You can decellularize tissues. So I had the same idea of that they had. I thought, why not decellularizing dental pulp? I got a grant, I got the money, and I did the research. And we published it in the Journal of Dental Research. It made the cover of the journal. I was proud of that. So it's a beautiful image. Basically, we developed a methodology to remove all the cells from the dental pulp. You just end up with a dental pulp that it looks like a fabric, like a tissue. And then you can put cells on top of that. And if you do that, the cells grow beautifully and extend processes into the dentinal tubules. It looks like this when it's decellularized. Looks like that, and then when it's repopulated, like that, they express DSP and alkaline phosphatase. The cells are odontoblastic, they differentiate, they mineralize if you use decellularized dental pulp. So basically, maybe one day a company is going to make this because we throw teeth in the trash every day. Wisdom teeth, they're extracted. We can just decellularize them, make a scaffold, and we're good. So just finishing, this is a hopeful outlook. I would like you to look at this case here. This child was playing baseball. It's funny that Dr. Sigurdsson showed that image of the bat and the father holding the bat. This one was different. The child was hit with the ball in the face, very heavy. So basically broke that molar there. See? The dentist saw and said, that's hopeless. How many of you just extract that tooth? I'm included. I'll look at it and say, that's hopeless. So the dentist sent the child to an oral surgeon. The oral surgeon found out that the child had a jaw fracture. So he decided not to extract the tooth because of the jaw fracture, had to consolidate. So he didn't do anything. They just waited. Look what happened. Waiting 1 year. And they tested the tooth was vital. Strange, right? Vital. Decided not to do anything. 3 years. What's going on there? Fracture is repairing. And the tooth remains vital. 10 years. Isn't that crazy? About 12 years. This is published in a chapter, the book chapter. Look at that. It's fantastic. Can I tell you that this is what's going to happen every time? No. This is one in a lifetime, I think, case. But it's amazing that dental pulp can do this. This is the Holy Grail. This is like you seeing a patient that has a cracked tooth and you telling the patient, maybe there is a solution for this. Maybe in the future, perhaps. But these also teach us to be humble because we are facilitators. I think we facilitate the repair that our bodies can do by promoting health. I like this cartoon a lot. This is a carriage that is out of control, and basically there is one guy here that's been chopped off here. This guy, sorry. And he went from A to B to C to D to F to stop the horses. He's the scientist. He's very cerebral. He's rationalizing the whole process. And the clinician is a little bit more decisive. He can stop things really quickly. So I think that we should be somewhere in the middle, right here. Okay? Thank you very much. Shukran. Questions?
Questions? Do you have an extra mic?
People still have energy.
Yes.
That's amazing. It's a lot of discipline. Must be the Arabic.
Hello.
And if I ask a question before, am I? Okay. Thank you very much. It was lovely. Now, as you present, you change a lot of thought. We believe in it, at least, I would say. Okay. We moved from antibiotic-free to 2. Then you are talking even about the sodium hypochlorite, from the concentration to different concentration, also the calcium hydroxide, the time. This move definitely is supported by histology, supported by your thought. What kind of resistance so far you are being through when you throw this information? You have somebody is resistant what you are saying? I'm sure about that, but I mean, what is the other side saying?
There's a tremendous resistance.
I know.
Tremendous resistance.
I'm one of them.
Yes, and I heard, but you're nice.
Yeah.
Some people are not nice. But it doesn't change the science.
No,
Science moves, right?
I agree with you. You have the support. I don't have support.
No, there's...
I am type 2 from the cartoon. Okay, clinician. I'm not... Yes, okay? And we go with experience, what we do in the clinic. Sure. That's what we do. But what you show today, now it's give us a big question. Are we doing this? Are we over-treating by the antibiotic, or where are we?
Even for us. And I think that's why it's very important that we keep in mind, because if all you're trying to achieve is healing, we can basically drop a nuclear bomb inside a tooth. Like full antibiotic paste. Why don't we do it in every tooth? That's a question I ask people. Why are you only doing it in revascularization? If it's that good, we should do it in every case. Every adult tooth, everybody. In fact, it makes more sense in adults than it does in immature, because immature, it might be killing other things. So I think that we just need to be consistent, and if things are moving a certain way, for me, what is more important is to keep a close follow-up, close watch with the patients. And not every case is going to respond well to calcium hydroxide. And when it doesn't, we use the antibiotic based. So we try first calcium hydroxide, and then we go antibiotic based. 6% hypochlorite I haven't used since 2010. Never.
I agree with you about that. Sodium hypochlorite is too much, this concentration. But my point is, why should I change if I have good result?
Good question. You should evaluate if your results are consistent and predictable. Because just to see cases working is one thing. To have a prediction that out of 100 cases you're going to get 85 working is a completely different story. So also, what is the rate of root development? Because healing, yes, you're going to get healing. I have no question. But how much root development are you getting? And we go further. And I had a nice conversation with a student that have a poster with a molar, beautiful molar case outside. And it worked, right? But what is the tissue that's formed? Are you getting a lot of bone? Are you getting a lot of this? We want to move to the next stage. And in order to do that, we have to create a condition that is more ideal. Or we're not going to never go there.
Yeah, I will go on. I will leave the chance for the...
Yeah, sure.
One last thing.
We can talk more.
One last thing. As a clinician, I'm talking about myself, and maybe some of our colleagues agree, is that we're going to stay as we are, okay? Unless you provide us with something as a scientist, with something that faster, more predictable, and give better result. But if you and me get the same result, why should I change my way?
You don't have to.
Yeah,
and
that's
that's
what I'm saying.
that's the
what I'm saying.
beauty. That's the beauty of this. Nobody has to do anything.
Yeah.
And some folks, when I present this at AAE, for example, some say I'll never use this revascularization, and that's okay. That's very okay. You have to look at the evidence and make a decision as a clinician. Nobody should be mandated to do anything. Evidence-based dentistry is basically evidence and experience of the clinician and patient expectations. I don't think revascularization is for every patient.
Absolutely.
There are many patients that are not good candidates for this.
I mean, it is, at the end of the day, we'll get the same result. Maybe we'll stay unless that we have a breakthrough that change everything. That time,
Right.
I think everybody...
Yeah, no, there's no breakthrough. No.
No, there will be, inshallah.
It's just building blocks.
Yes.
Building blocks, yes.
Thank you.
You're welcome. Yeah.
Please introduce yourself, your name, your affiliation.
Yes. I'm Mayel Habib. I'm an assistant professor in King Abdulaziz. My question is, when you took samples from the intrapulpal blood, you tested for the CD markers. Have you looked into STRO1? Because it's more exclusive to stem cells than the CD markers.
Yes, we have. And in that paper from 2011, if you look at the immunocytochemistry, the surface marker that we use was STRO1. So the cell is lit up with STRO1. So we looked into that.
Perfect.
Yeah.
And the other question is, how do you still get APT positive when the coronal is full of restorative material?
Very good question. Basically, you're applying current through a tooth. And the current, it can travel through a whole tooth structure. And what it does, it depolarizes by activating voltage-gated sodium channels. The same one that I talked about yesterday. So we have those fibers in there. I showed you several cases with boards, including ours, and they have sodium channels. So that's how APT works, is by activating the voltage-gated sodium channels.
Thank you.
You're welcome.
Thank you for this very informative lecture. Dr. Amira, Associate Professor, Taiba University. I have a couple of questions actually. First, you didn't mention the rule of MTAD. I know the standard is sodium hypochlorite and chlorhexidine. What's about the MTAD? This is the first. And the second, what the rule of PRP and PRF? Is it minor or is it major rule in regeneration? Thank you.
The one is MTAD, right? I haven't looked into MTAD. All the groups have. I think Peter Murray have looked into that, but he didn't look at so much differentiation. He looked at attachment, and cells seems to survive MTAD and attach. So that's okay. That's good.
Cytotoxicity of fibroblast, you mean?
Huh?
About the cytotoxicity of fibroblast attachment?
Yeah, and cytotoxicity.
Yeah, okay.
Yeah, and your second question was PRP?
And PRF?
PRP and PRF, I think they're very fine. In fact, they have all these chemoprotective factors. In animal studies, at least, they don't seem to give any better results than the blood clot. That's number one. Now, in humans, I think that there is an issue with getting blood from children. I think, at least in my clinic, it will be difficult. They are usually sedated, and it's hard to do these procedures in children. And I'm sure you could get from some, but it's hard. It's hard.
Yes, it's not applicable. Thank you so much.
You're welcome.
Should I ask a question?
Yeah.
Thank you, Dr. Lagni. It is an interesting topic. That's why everyone is want to ask questions. The lecture was really nice. I'm just asking if we are very sensitive about definitions. If regeneration is replacement of damaged tooth structure, in immature teeth we don't have damaged tooth structure. We have tooth that stopped growing, and we aim in continuing the growth of the root. So I don't know about regeneration or repair. if we are very sensitive about definitions?
No, I'm not. I think this is semantics, okay? It's terminology. If you say it's damaged, I'll say it is damaged because the dental complex is damaged because it's necrotic. It's infected and underwent necrosis. So, to me, that's the highest definition of damage, right? If you just look at the root surface itself, maybe it's not damaged. More likely it is because we also have resorption and all that. And the bacteria that's in the dental tubules shouldn't be there. To me, that's damage or damaging. So it depends how you see things. I'm not caught up on that at all. I'm a clinician. I also have guns. I like to stop things when I can, but I'm also a scientist. And from a scientific perspective, I know it's important for us to go for the regeneration from a clinical standpoint, the repair that we're getting and the healing rates. I'm already happy. But it's not for everybody, again, in every case. As a specialist, I don't treat anybody like they're the same. It's very custom to the patient. So I'm not caught up with the definition, I'm not.
Okay, in necrotic teeth, can we say we are applying regenerative endodontic concept, which is scaffold, growth factors, and stem cells, but the result is not always regeneration?
Correct. It's repair.
Very interesting discussion. We have one question for the lady in the white scarf, please.
Hello, I'm Nauf Sharian, endodontic resident at King Saud University. I have one question regarding the traumatized immature teeth. You said that they have lower success rate, but I don't get why. If the dental papilla is there, why you can't regenerate? Unless the trauma impacts the dental papilla.
Yeah, again, great question, by the way. I'm glad you got the chance to ask. Here's the thing, how do you define success, right? If all we want is healing, I don't think that's an issue. But root development is where we see the lower rates of root development. And I believe it's because trauma more likely damages the interaction between the apical papilla and the Hertwig's root sheath. For example, an intrusion or lateral luxation. When teeth self-revascularize, what we see a lot of times is a root that grows like this, right? After trauma. Because that relationship was disrupted somehow. And I think that's what happens with trauma. I think. Can't prove it. But it's proven, at least in animals. There are some animal studies in which they went and then they disrupted and the roots didn't grow. Okay?
Thank you, Doctor, for this nice presentation. I'm Nur Al-Houesh, endo resident in King Saud University. I have a question regarding the in vitro studies using dental pulp stem cells. How can we interpret these findings since we are using stem cells of apical papilla in the clinic?
Which studies with dental pulp stem cells?
Dental pulp stem cells are being used in vitro investigation.
Oh, in many studies?
Yes.
Yeah. Well, yeah. That's why I don't use them. I can't.
So these results are not representative?
I think they are. They are. These cells are not the same. They're very close cousins. And I think you can, for studies that have used dental pulp stem cells, I haven't seen a single one that was not confirmed with a stem cell of the apical papilla. I think you get the same type of results, but I cannot guarantee that everything is the same because the cells are different. And that's why I don't look at them, because the teeth that I treat are fully necrotic. So those cells are not going to be there. I don't know if he answered, but it's my most honest assessment of yes.
Ragab Saif, why you rely on the EBT to evaluate the sensibility of the tooth in this young immature tooth, in spite of will not rely on the EBT to evaluate such sensibility normally?
So I don't know if I got everything. You said, why do I use APT?
APT, and you didn't use cold test to evaluate the sensibility.
We do cold tests as well. And
I heard only APT in the lectures.
if I only use
APT is positive.
no, we use every methodology that we have. I mean, you cold, EPT. Cold, it's more difficult to get a response just because you need to, it depends how deep the restoration is. Even EPT, it depends how deep. If you have very deep restoration of MTA all the way to half of the root, the current needs to travel further down. Now, whether we get false positives because they're children and they're going to respond anyways, that's why we need to treat them. What we do, we put the probe with the machine off on the tooth. And that if the child raises their hand, they're lying to you. So there are ways that we can do to treat them. Even with cold tests, we put the cotton on the mirror, close to the tooth, and the child sometimes responds. So we run tests with them because they're not reliable. I think that's where you're trying to get, right? Okay.
Second question, can you use stem cell to treat apical periodontitis?
I'm sorry?
Can we use stem cell to treat apical periodontitis?
We can use
stem cell to treat an apical periodontitis?
I think that this is a good question. I think it's going to be very important for us to develop as a field, not only for root development, but for healing of apical periodontitis.
Because you mentioned spinal cord inflammation are treated by dental papillae.
Correct. I don't know if you've seen a clinical trial from Italy. They got dental pulp stem cells, and they implanted them in sockets of periodontal defects, very large sockets, and they got massive bone growth within patients. So I'm pretty sure that it could be used for healing of apical periodontitis too. And it's an area that is untouched and needs to be investigated.
Thank you.
Yeah.
I'm really enjoying the discussion, and it's really nice after this very exciting presentation, evidence-based, and some zebras like the last molar, and it was really interesting, and I really see that with the questions and the discussions, a very rich discussion. On your behalf, we must conclude. So on your behalf, I would like to thank Dr. Diogenes for this excellent presentation and for him being here in Saudi Arabia, and also for hosting some of our former students to be endodontist. So I thank him on all of your behalf.